Hi everyone, thanks for joining. Today we have 45 minutes, one question, one follow-up. We have Dr. Brown, Dr. Huyer, and Dr. Williams here today, so I'll turn it over to Dr. Williams to get things started.
Okay, well, good afternoon. It's Thursday, and we'll give you updates of how the week has gone with the data. But before that, as we promised 2 weeks ago, we would bring Dr. Brown back with a further update on the modeling and the analytics in that, and then Dr. Huyer is going to talk to us about some of the outbreak aspects and the projections on the trends and the outbreaks. And then I'll finish up with some numbers and comments, and then we'll have questions. So I'm going to call Dr. Brown up to the podium for him to do his presentation. Thank you. Welcome, Dr. Brown.
Thank you, Dr. Williams. Today I'm going to present updates of the statistics we presented last time. I'm going to provide some update on the modeling, and I'm also going to talk about some of the issues in the distribution of the disease. I want to make sure that I say thank you to the analysts, modelers, and researchers at the University of Toronto, at McMaster University, at Ontario Health, at Public Health Ontario, at the Ministry of Health, and at the University Health Network, at Unity Health, and at ISIS, all of whom for this presentation have contributed data and analyses. I should note as well that as we go to the slides, the interpreter will disappear momentarily. I'm sorry about that, but that allows us to present the data as well. If we could go to the next slide, please, the key findings. So I don't want to belabor the key findings too much, but there's a few points that are really, really important to keep in mind. The key indicators of the pandemic right now are flattening in some regions, but the impact of the pandemic and the actual direction of these indicators still varies substantially across regions. While it's positive to see that these indicators like cases are starting to flatten, it is best described as a fragile or precarious situation where we need to make sure that cases continue to flatten and decline before we can say that we're making strong progress. Long-term care resident mortality continues to increase, although cases are now flattening and starting to decline. ICU occupancy is now over the 150 bed mark that we noted was likely in the last presentation. And under any of the scenarios that we've contemplated, it will be over 200 in December. It's difficult to determine right now, though, whether or not we are seeing a true turnaround in cases. And so keeping in mind that ICU occupancy will only change about 2 weeks or more after that decline in cases, it's too early to say that we're really going to see anything with ICU yet. The access to care overall continues to be below 2019 levels, so the access to care deficit continues to increase. And I think importantly today we'll spend some time talking about how some communities face a much higher burden of the pandemic because of long-standing structural factors that lead to higher exposure to COVID-19. And the importance of this is that public health interventions that we've contemplated so far that by definition affect everyone the same way, they're one-size-fits-all interventions, are unlikely to have the same impact in communities that face a much higher risk of exposure and thus are likely to not be as effective in curtailing the pandemic in those communities and eventually in the province overall. If we could go to the slide they're up now, thanks, that's great. This slide updates the total new cases per 100,000 residents per week across the public health units. You can see it's going from a 7-day sort of average of about 170s up in Peel down to about 10% of that down in Eastern Ontario. So substantial variation, but I think important to note the variation and the movement up and down over time within virtually every one of the public health units we're looking at, giving this idea that we are not really turned a corner yet. We may see flattening, but really we're in a very fragile or precarious position. If we could go to the next slide, please. This is the new cases with no epidemiological link across public health units. In a situation like this, where we've got very high case counts, we would expect to see a lot of community transmission, which raises those numbers up. But it's a critical measure of public health capacity that hopefully as cases decline, this proportion will improve substantially so that we know the source of cases, and in that period following the second wave, we're able to make sure that we stay on top of outbreaks and make sure that we understand where cases are coming from. And you can see again here substantial variation ranging from up in the 70s again in Toronto to down under 10 in the lowest public health unit, indicating again this almost tenfold variation between the lowest and the highest, showing the variation across public health units. If we could go to the next slide, please. This slide shows COVID-19 testing percent positivity across public health units. As we've talked before, we don't rely just on one indicator. We're looking at case numbers. We're trying to look at percent positivity. We're trying to understand that testing volumes stay the same. And when all those move in the same direction, we have a good read on where the pandemic is moving. When they don't, we tend to have some trouble with interpretation. In this case, once again, you see the tenfold variation between the highest percent positivity, which is over 10%, of tests in Peel, down to under 1% in the Eastern Public Health Unit, showing and really reinforcing again the fact that this is not a single pandemic across the province, but really a series of individual micro-pandemics or micro-epidemics that require different approaches in different regions. If we could go to the next one. So this is again now looking at another key measure of our ability to respond to the pandemic. This is the percent of tests processed within 2 days across public health units. I'd want to note again that it's not public health units that process the test necessarily, but you do see variation again in the time that it takes for a test to be returned to people in these public health units. Up over 90% in York, down to almost 1/3 less in Brant, giving you a good idea that there is still again variation in what is a key measure of public health system capacity to respond to the pandemic. If we could go to the next slide. So this slide is challenging to read because there's an awful lot of information or data on one slide. This reflects the percent positivity over time by age group. The youngest age groups are at the bottom of this chart. The oldest age groups are at the top of the chart. And as you move from left to right across the chart, you see really that tail end of the, or not the tail end, but the middle of the first wave of the pandemic, with very dark numbers during this time, becoming lighter during the summer as the percent positivity drops really across all age groups, moving on to the fall where we are now, and again this second wave and much darker colors again. What is positive here is that the percent positivity is generally going down across all age groups. And so we find ourselves in this place which is, as we said, sort of a fragile moment where if we're able to continue to decrease case numbers, you'll see improvement in the pandemic, but a small number of outbreaks could dramatically increase case numbers and take us back up onto what looks more like a worst case trajectory. If we could go to the next slide, please. This slide updates the slide we presented last time on mortality and cases in long-term care homes. The green line there is the cumulative deaths. And you'll see that deaths have increased again over the last 7 days by 64. This is lower than what we reported the last time. But as you can see, deaths are continuing to increase. The case numbers are important to look at here because the cases have peaked, it looks like, and starting to come down. That's a positive indicator. And I think reinforces the fact that the age distribution of cases in this second wave is very different from the age distribution of cases in the first wave. In the first wave, we saw a very, very high number of cases in people who were in our oldest age group. We don't see that, or at least it's not the highest spike in this round of the pandemic. As cases come down, you will see lagging indicators like death also start to come down, but that will not show up in a significant way for at least a few weeks, if not more. If we could go to the next slide, please. So this slide updates the first of the modeling slides from the last presentation. And I think it's important to kind of note where we were at the last presentation and where we are today. In the last presentation, we were looking at the growth in Ontario compared to other jurisdictions, and looking at a growth rate in Ontario that was somewhere between 3 and 6% over the last few days. Here, we're now in a better position where the growth rate is really between 0 and 1%. Now, this is a challenging situation where we kind of see flat cases to understand where the models are going to go. We've had modeling done at Public Health Ontario as well, and at McMaster University as well, in addition to these models that were done at University Health Network and University of Toronto. And what you see here is a number of different situations that I'll try to make sure are clear. If we continue on the current level of cases, if there is no further growth in the rate of new cases, We'll sort of flatline there, and that might be considered a conservative version of a best case scenario right now. That's that bottom line that says Ontario 1.00. That's reflecting our last 3 days of growth in cases. As we get sort of to higher levels, you can see 1.01. That is the growth if we are a little more like our last week's worth of growth. And then you can see more significant rates of growth at, say, 3%, which was our perhaps baseline scenario in the last briefing, which takes us up above Germany and France in terms of trajectory. And you can see 5%, which is where we were heading at the beginning of the last briefing over the 3 days, takes us up to an even higher level at a similar time in the pandemic compared to the Netherlands and to Michigan. So what you see here is we're not modeling a decrease in cases right now. It's a little too early to say in this sort of fragile position whether cases will come down, although they're flat right now. And with a sufficient number of outbreaks, you could see much higher rates of growth even than the 1.05% that we've noted here, and as we've seen in some jurisdictions. We could go to the next slide, please. Perfect. So this slide updates the slide on COVID hospitalizations and COVID ICU use. What you can see here is a 63.2% increase. This is slightly up from the 61% that we reported last time. But remember, even with cases flattening, hospitalizations are going to continue to grow for a while because of the progression of the disease and the time it takes to go from infection to symptoms to the requirement of hospitalization. And ICU use will lag even further behind that. So about the same level of growth in hospitalization, but that makes sense even with the recent flattening over the last few days of cases, given the natural history of the disease. If we could go to the next slide, please. And this slide presents the projections on ICU occupancy. Now, of course, the health system is made up of many more components than just intensive care units, and it's important to note that the pandemic affects virtually every aspect of our health system. But you can see under all of our models, we are over 200 cases, or 200 beds in ICUs, intensive care units, in December. And so even with what seems like a flattening now, the progression of the disease through the population and the worsening symptoms in some of the population means that we will see further growth, or we're very likely to see further growth in intensive care unit occupancy under any of the scenarios. I think it's also important to note that under the flat line scenario, which is maybe a conservative definition of a best case scenario right now, occupancy does stay above 200 beds for a fair period of time. And at that level, hospitals are facing significant capacity challenges. They are facing significant threats to the sustainability of their health human resource workforce. And they are making decisions to cancel, postpone, or delay treatments that are necessary. Also, maybe worth noting that the initial modeling or last briefing's modeling had said that we would exceed the 150 mark, which is the threshold. We've now exceeded that. Thank you. This slide describes the access to care deficit in the province, and you can see really that blue shape behind the graph, that sort of thing that looks like two peaks. That's the first and the second wave volume of cases right there. And you can see, for instance, in purple, that is the line describing the amount of surgery in 2020 compared to 2019. And you can see in the first wave there is a dramatic drop in the volume of surgery performed in the province. This creates a deficit in surgery. It reflects people who needed surgery but were unable to likely get it. You can see it coming back up with the different directions to restart surgery and to resume readmissions or returns to long-term care homes. However, it's now back down underneath that red line, which is the line indicating the 2019 numbers. And you can see here the effect of the pandemic continues to decrease access to care. You can see a similar line for diagnostic imaging, which is the beige line. You can see a similar line for virtually any of the types of care that we're tracking here in this chart. I'll just say it is important to interpret the last little period of time in this chart with caution. These numbers do change as they get updated, but it looks with all of them to be continuing well below the line for 2019 volumes. This chart, I think, starts to show some of the important variation in the pandemic and its impact on communities. So for every of the briefings that we've made the point that the impact across public health units is highly variable, that it varies substantially across regions. These maps show you the percent positivity across a smaller unit of geography, across smaller communities. These are what are called forward sortation areas, which are just the first three digits of your postal code. And so we're able to look at the percent positivity on testing across forward sortation areas. And you can see that it is, again, even within public health units, very unevenly distributed. The dark purple indicating places with high percent positivity, and the lighter colors indicating lower percents, and the white where the numbers are essentially low enough not to be calculated. If I showed you the chart for cases, you'd see a similar distribution of cases. Really, if you looked at these charts for almost any of the measures of health or disease status across these areas, they'd look very, very similar. But this gives you an idea that there are communities that are facing and have faced consistently or persistently much higher levels of COVID-19 infection. We go to the next one, please. Now, it's important to understand what is driving this and the time period that this is happening over. So this chart talks about, over on the right-hand side of the page, talks about the level of infection, or the cumulative level of cases in different communities across Ontario, again, defined by the information that we have through census and other types of material. And it talks about different communities broken down by whether or not there is suitable housing. And suitable housing means nothing more than there is enough room and enough appropriate room in homes for the number of people living in them. And you can see in that red line, which is the 10% with the lowest level of suitable housing, the level of COVID infection is the highest, and it has been the highest in both the first and the second waves. So it's important to note that this is a consistent phenomenon. Even during our first lockdown, the level of infection was much higher in these communities. And you can contrast this with the second wave, with the lowest line, which is the blue, the medium blue, which is the communities with the highest level of suitable housing. And you can see here again, essentially through the first and second wave, they have had the lowest level of COVID infection. You can see very similar charts if we were to talk about the number of people in essential services, those people who are not able to work from home, who are not able to isolate or shelter in a home during the pandemic. And it's important to note that these are long-standing structural factors here. These are not transient or things specific to the pandemic that drive these much higher rates of infection. This is the last of the charts with data. What you can see, though, is that this creates what we call a prevention gap. Essentially, if the risk of exposure because of housing or because of the nature of employment is much higher in a community, public health interventions that, by definition, in this case, are sort of a one-size-fits-all solution, do not have the same impact across communities. And so whether there's a high rate of exposure and a low rate of exposure in a second community, and community A or neighborhood A is that with a high rate of exposure to COVID-19, community B is the community with a low rate of exposure to COVID-19. When the same interventions are applied, they create very different reductions in the level of COVID-19 exposure, very different impact in terms of reduction in the number of cases. This is important because if we take a one-size-fits-all approach with efforts to reduce infection, you'll see this prevention gap open up in these communities with these long-standing structural factors. Infection will remain higher, and actually that will, in the long run, make infection across the province higher as well. So it is not something that can be just isolated within these communities either. Coming to the last slide and just reviewing the key findings. So key indicators are flattening in some regions, particularly those with the highest rates, but the variation in performance against these key indicators across all of the public health units continues, indicating that we are not in a stable or declining situation of the pandemic now. It is still too early to call. Long-term care home resident mortality continues to increase, but cases are declining. ICU occupancy continues to increase. We're over 150 beds now, which was the first threshold at which care is compromised. We're likely to get close to 200 or more in this next month, sometime in December. And that's likely under any of the scenarios, even the best case scenario that we modeled in this briefing. It is difficult, I just want to emphasize, to say whether or not we are seeing a true turnaround in cases. This is a moment of great sort of precariousness where continued sort of adherence to public health measures will hopefully bring case counts down. But outbreaks or challenges in maintaining those public health interventions will actually lead to a growth again in the cases. Access to care continues below 2019 levels. We showed a variety of data for really hospital-based care, but that continues perhaps across a number of different areas of care as well. And some communities do face much higher risk of exposure to COVID-19. This is due to long-standing structural factors that are beyond the control of any of the residents of those communities. And so one-size-fits-all public health interventions are unlikely to have the same impact in some of our communities. With that, thank you, and I'll turn it back over to Dr. Huyer.
Thank you, Dr. Brown. Thanks, Dr. Williams, and good afternoon to everybody. Just a brief update so we have room for more questions. From the outbreak perspective, today we're reporting one of the highest numbers that I can recall of 48 new outbreaks, and that certainly is concerning. Over 7 days, as of yesterday, we had reported 212 over the week period of time, and over 30 days, 748. I also just want to take a moment and speak to what Dr. Brown had spoken about, and I think Dr. Williams may, but just a special note of sadness and recognition of those that have lost their lives. We had 35 people who lost their lives or reported today, and 21 yesterday. This clearly is a tragedy, and all our hearts go out to those family members who have suffered such tragic losses. Thinking about the outbreaks, we did see an increased number today in workplaces and also in public-facing environments, and still see a continued number of outbreaks in long-term care homes and other vulnerable sectors, as well as schools. Important to think about outbreaks and what do they mean. It's difficult to be specific, as that is the only measure. It's definitely not the only measure of the work that we've talked about. And as Dr. Brown showed, many of the public health units were reducing the number of situations where there was not an epidemiological link, so a number of negatives there. Essentially what I'm saying is more cases are determined at source than had been in the last presentation by Dr. Brown. And so it hopefully speaks to how the public health units have greater capacity and improving capacity to be able to further understand these. So the number of outbreaks may in fact be also representative of that additional work and capacity that they're able to demonstrate, as shown in Dr. Brown's slide, one of the slides around the percentage of epidemiologically linked cases. Having said all of that, it still is very important that despite the fact outbreaks are a smaller number, they are a representation of the spread, and not only have we seen more, but we've also seen them in multiple areas across the province. I remember early in the days when I was presenting here, we would talk about the majority of the outbreaks being in the settings that had the highest case numbers, so Toronto, Peel, at that time Ottawa and York, and with occasional outbreaks in some of the outer settings. We now have lists of outbreaks in the outer settings, and we continue to see that number grow and the range increase over time. So representative of both the spread and also the complexity of the cases. I think Dr. Brown has also spoken about a number of important aspects as far as the healthcare capacity, and also the importance of determinants of health and how to support determinants of health to be able to ensure that we provide the best opportunity in all ways to help people avoid transmission, and if they do potentially have transmission of the virus, provide opportunity for testing and health care, and ensure that we do the best that we can to make sure that, as was said, that we have a regional approach as appropriate, as opposed to the one-size-fits-all. I'm going to pass over to Dr. Williams at this point. Thank you.
Okay, well, thank you, Dr. Brown and Dr. Huyer. Since we spoke to you last Monday, we've had an additional 3,860 cases. And our 7-day average moved up to 1,427, which was compared to 1,370 a week ago. So, as Dr. Brown said, while it may look like we're plateauing, we're still in a very precarious situation. We have to really remain focused and see if we can continue to keep this plateauing going and see if we can actually make it turn. But it is at that situation where it could pivot either way at this time. So we can't let our guard down. We have to continue to be vigilant in all the steps, which you know, and I'll talk about in a moment. 64% of the cases are in our areas of Toronto and Peel, and as Dr. Huyer's alluded to, we've seen that shift a bit, and we're getting more and more out in the outer areas. And with our aspects, we will be looking at if there's going to be changes in the health unit's status on the framework. I can't give the details of that, but I can say we're not recommending any new ones go into lockdown at this stage. But there will be some other movements within the different color zones that we'll be bringing to you tomorrow. Again, the cases in Peel are the highest with 572. And as Dr. Huyer alluded to, we still experience, unfortunately, deaths. And since Monday, we've had 70, including the ones that Dr. Huyer alluded to today and yesterday. In the projections, as Dr. Brown's alluded to, there is some positive signs we're seeing, a good direction, but it's still precarious, and we have to watch that. And we're not as bad as we were, but we're not out of the woods yet in this matter. So we have to continue to do our care in each of our zones to follow all the directions and restrictions and limitations, including that of the ongoing distancing, masking, the numbers of gatherings in places, in lockdown ones and others with households in some cases, limiting the amount of activity outside and going for essential functions only. And as I said, it looked interesting. We're already seeing it dipping a bit in Peel and Toronto and some of our red zones. That is encouraging. And the ones where we're seeing rise is more in the outer areas over their previous week's numbers. So these indicators are reassuring, but the measures still have to continue as we keep to drive these ones down and see if we can get people progressing out of the lockdowns or red zones and dropping down further. So while we see Ontarians are willing to follow the measures, we find more and more, or some are resisting that. We really want to ask that you stick to the task, stay really focused on all those measures that have proven effective up till now. And if we do it again and do it effectively and efficiently, we can continue to turn the curve and come off the precarious situation that Dr. Brown alluded to and coming down into the slope going down the other side of the second wave. And that certainly would be a good thing to start to approach as we head into the month of December. But there is the aftermath of the high numbers, as Dr. Brown alluded to, with the hospitalizations and then the following on suit of that of the ICU admissions that still will have an impact on the healthcare system. So promising, but not totally predictable at this stage, so we have to be careful. So let's create the task and let's see if we can do it and keep turning it in that way. And I thank all Ontarians for doing their part, and we continue to work at this. So with that, I'm going to open up for questions to either Dr. Brown, Dr. Huyer, or myself from the media.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
Your first question comes from Christina Tenalia with CP24. Please go ahead.
Hi, everyone. Thanks for taking my question today. Oh, sorry, there was getting a bit of feedback. Let me start that again. Thank you for taking my question today. I'm wondering if you could provide some clarity. So 2 weeks ago, when you all unveiled the province's modeling numbers, it showed that Ontario could see as many as 6,500 new daily cases by mid-December, unless more steps were taken to limit the spread of the virus, or 2,500 new daily cases by that time if the growth rate was at 3%. Again, let me clarify, 6,500 if the growth rate was at 5%. I know you said, there's a bit of a lack of clarity because we're still in a precarious situation, but what would be the number now?
Dr. Brown, speak to that.
Thank you for the question. So under the different scenarios we're looking at now, given this sort of what we see as flattening the number of cases, if we are able to maintain the current level and not see further growth, you're likely to see about the same number of cases a day by the end of December. So that will not change compared to what you see today. If, however, it goes in a very bad direction and we see from today on that type of growth that we were seeing 2 weeks ago, you'll see north of 9,000 cases, which is the type of growth that we've only seen in a small number of jurisdictions.
Okay, thank you. And I wanted to ask you again, Mr. Brown, about one of the final slides there where it discusses people living in their homes, the size of the home and the density. You acknowledge that this is a structural matter, and it was the same in the first lockdown, and people are most impacted in neighborhoods with those homes. What are those neighborhoods? What regions are they in?
So those regions are mostly in Toronto and Peel when we look at it. They are the communities that you've seen with persistently high rates of infection that have been discussed. Maybe one of the things I do want to note, though, is where neighborhoods and health partners or health providers have worked in partnership, as we see, say, perhaps in some areas of East Toronto, you have seen a dramatic decline in the actual rate of infection following that type of partnership and tailoring the interventions to those communities.
Question?
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hi, doctors. I just wanted to go back a little bit to that slide that Christina was just asking about. So the Ontario 1.05, that's, just to clarify, that is 5% growth. And right now you were saying, I believe are we at 1% growth?
Dr. Brown said that it is 5%, and we're between 1.0 and 1.1 at this time.
All right. So do you have any sense then So is the lockdown working? Are the other measures increasing, moving up other areas to the red zone and other lower ones up into the orange zone, et cetera? You said we're precarious. I'm just trying to get a sense of how all that is working.
So there's a composite across there, and I think from the modeling, the data that Dr. Brown's updated you on, is that we were looking a week ago at the 1.033% and the 5%, and we were trending in that direction. It's reassuring that across the overall numbers are now between 1% and 1.1%. So that's an improvement across the board. Some in the larger ones more, like the lockdown ones, and there's a variation. Some are still increasing in the regional areas, where you'll probably see some greens going to yellow and yellows going to orange. But overall, the province has moved down from that 5% possibility, 3%, down to the 1 to 1.1% at this time. So it would state that the framework and the different restrictions are having an impact, and people are restraining and continuing to follow those procedures in that way. So I think it's showing the effectiveness of it. Is it enough to drive us firmly down the other side of the slope of a second wave? That's where we said we're at the precarious part at the top. We're not sure yet. Optimistically, we could say, but we have to wait and see.
Next question.
Your next question comes from John McGrath with TVO. Please go ahead.
This is more of a reading comprehension question, I guess, perhaps for Dr. Brown. On the November 12th briefing, we were shown a slide that said that if Ontario, this is like the Ontario 1.05, like the worst case scenario, we could reach the 350 ICU bed threshold by mid-December. And if I look at slide 11 in today's briefing, that no longer seems to be part of the range of possibilities. Is it correct to say that the worst case scenario is not quite as bad as it looked 2 weeks ago in terms of ICU capacity?
Question over to Dr. Brown.
Thanks. So the short answer to your question is that's correct. You're reading it entirely correctly. What happens is that every time we release these models and every time there's public health measures, the growth rate in cases goes up or goes down. In this case, as you've seen the cases start to flatten now, that's essentially sort of changing what our worst case looks like. And so although if we got back onto the same trajectory of growth that we saw just before the last presentation, we would get up to that very, very high level of cases, over 9,000, as I mentioned, within about a month. And the ICU occupancy would go up to about 400 But right now, at this current level of growth, it's actually not quite as bad as it might have been. And if it stays or comes down, you'll see the ICU use, you'll see all the other indicators start to trend down as well after a period of time. I think it's really important to note, though, that even under what we're currently modeling as the best case, which is 0% growth, given where we are in this rather fragile state, you're still going to see ICU occupancy stay above 200 beds, at least until the end of December. And that's a challenge because that is above the threshold now at which hospitals are able to kind of cope with the surge in COVID patients.
Follow up?
And this, I think, is maybe more generally either for Dr. Williams or the question of, or rather the key finding near the end of some communities facing a much higher burden, that this is connected with insufficient housing and occupational hazards. This hasn't been something that, well, I know there's been Ministry of Labor work and that kind of thing, but will you or will there be more additions to the framework? Will you be making advice to the government about additional measures to either increase things like supportive housing or greater Ministry of Labor enforcement or any other measures to focus on these areas where the infection is still greatest?
Well, thank you for the question. And I think what you've addressed there is what we're trying to address as the data has become apparent, that where we have these areas with larger members living in a single household, not necessarily reflective of low socioeconomic, but it just seems to be that higher risk of exposure, and tells you how COVID spreads among a group with close proximity in that period of time. But it makes it very clear that our strategies as one fits all, as Dr. Huyer alluded to, will not be adequate, and we have to look at ways to try and connect with those various community groups and other ones to look at strategies much more along our lines of community action and different steps there to deal with it, from a working with the communities to say, how can we help you address the issue, help individual families and groups and people in there. If there's precarious situations, is there things that we should be offering, say, from the province, or is there more things at the local level, either through the community leaders, through the local public health unit, community health centers, other agencies and groups at that level, to impact and work with them, including more targeted enhanced testing and different ways to try and assist the communities, because they want to get those numbers down as well. And how do we facilitate that? So we're having work reports from the science table. We received some reports. We're getting more reports from our groups working on case contact management, and from health units on ideas and strategies that we would use this for these unique areas, because the main thing you've heard today is that it's a wide variation across the province. Certain things work better in some areas than other areas, and here's a unique challenge in two of our most highest areas of lockdown, that we have to even get more granular, if you may, and work at specific targets there to help those people to get their numbers down, because they want them down as well as anyone else does.
Next question.
Your next question comes from Jeff Gray with the Globe and Mail. Please go ahead.
Oh, thanks. I just wanted to ask, a lot of cautious optimism, very cautious optimism here, but there's nothing in these numbers that would lead any of you to suggest that some sort of modification to the lockdown, sort of to maybe loosen or allow some limited shopping in non-essential stores, this kind of thing, the kind of thing that business groups are calling for. There's nothing in here that would suggest that that's something you would recommend.
So you've heard the word from Dr. Brown is precarious. And to look at any shifts and changes at the moment that would threaten that is one would have to be done very carefully, because we haven't seen the full impact. We're coming up to our second week, so it's too early to say yet and to shift that. The encouraging part is that we're seeing these things potentially turning, and no one more than I would like to see it even moving more aggressively down in there, and that allows us to look at things, because if you can move people with numbers out of a lockdown zone with the 28 days we put originally into other zones, that would facilitate that process. So we're watching those numbers weekly, and we really need to see them coming even further promising. at this time, and we're only halfway through our second week, and so it's still too early with the time of incubation and transmission, et cetera, and testing to make sweeping conclusions on changes at this time. But we continue to watch and monitor and try and seek the best situation to get our numbers down. We want to be out of this second wave.
Follow up?
And just picking up on some of the stuff you mentioned there, just about the one-size-fits-all intervention of shutting a large number of things down versus more tailored interventions to address this issue of, I guess, people living in households with a lot of, multi-generational households. Are there specific things that are being looked at to try and sort of micro-target at those communities? You mentioned a couple of them, but are there other things that could be done or that are on the horizon that would really try and contain the spread there?
Well, I alluded to some of the aspects there because if you're asking about where you have areas where there's large extended families in one household, there you may have people in that household, 6 or 7 who are employed in various locations all over the place, and some of those positions may be positions that do not have paid sick leave. They may not have ones that have any certainty, and so then if you're asking isolation, but the whole group has been exposed, how do you help that family, that group, do the proper isolation, get the supports they need, and still be able to have the means to pay for costs and overhead and food and other necessities of life to make that work. So you have to facilitate that and look at models of how you might address that in those type of settings. There's some others in other parts of the province that are doing different things where they're working with different groups and ethnic groups and different ones that they know they're trying to address and make the best strategy, because each group wants the numbers down. They don't want COVID. And how do we work best with them? And because they have the answers to that, and so we're trying to do that even with our First Nation communities, working with them. What do you want to do? How do you want to handle this? And we're continually in communication with that because they know what's best for their solutions if we can help them and facilitate and support them in that regard.
Last question.
Your final question comes from Jessica Smith with Queen's Park Briefing. Please go ahead.
Hi, thanks so much for taking my question. I was just hoping that Dr. Brown could sort of elaborate on the one-size-fits-all versus targeted intervention. So I think one-size-fits-all refers to like a lockdown or broad restrictions, but what are some examples of things that would be targeted and effective at helping people with that higher risk of exposure?
Thank you for the question. So it's really, I think you have to consider this on three lines of work. So one of which is the grassroots work, working with community leaders to make sure that there is support for people to isolate at home, to make sure that messaging is appropriate and effective and compelling around the pandemic, to make sure that there is support for people in their communities, really designed, as Dr. Williams said, with them, not for them, in sort of a one-size-fits-all approach. There's also got to be, obviously, attention to testing, so that testing is popping up in those places where it's most needed, and that's accessible to people, that it doesn't require maybe some of the typical barriers that are in place in testing, like driving or other types of scheduling. So walk-in testing, for instance, close to hotspots of infection, as they did in East Toronto, is a great idea. And finally, there are top-down or system-level things like protection against eviction or income support or sick pay that can be quite helpful as well.
Follow up, and this is the last question.
Thank you. Yeah, my follow-up is for Dr. Williams. I heard you mention paid sick leave. Is this something you think the province needs to implement, Dr. Williams?
I think when Dr. Brown was alluding to there, if you're asking people to isolate for a period of time, there are some people that have methods to maintain those necessities, which includes if you have overhead costs, rent and heating, etc., and aspects related to the purchasing of necessities of food, someone to bring the food in. So there's service needs, there are functional needs, and there may be fiscal needs as well, because if they are not, if they can't access forms to support them during the 14 days, what solutions could be found to assist that? Because we need to help them however we can all citizens in Ontario, wherever you are, to do your 14 days in your time of quarantine or your time post-positive test, so that you're not spreading it to anyone else in your family or anyone outside your household, which includes, as always, our concerns into our institutions, especially the vulnerable in the long-term care, as well as in our schools. So we want everybody to do their part, and however we can help you through education, information, advice. And here's examples that you've heard Dr. Brown allude to, that if we're dealing with unique challenges in certain areas, how would we help that? How would we facilitate that? Because we all win by doing that as well as they do. So you gave a good example of one thing. We have to consider everything that might help and assist in this matter to drive us down the second wave. So thank you.
Thanks, everyone.
Thank you.